We have Miriam here, and I think this is quite an interesting question. She says, what if the withdrawal symptoms start months after the last dosage? Because this sort of thing happens, doesn't it? People get a kind of delayed reaction type withdrawal.
I think that's a very good question, and given the time, it was impossible for me to discuss this, because this is, of course, a very comprehensive, not comprehensive, but very, well, I could not discuss all, because, of course, withdrawal symptoms occurring after the tapering, that's something we don't know enough about. We know that it happens, and that's why when people use tapering strips, when they get a last one, we tell to them, if you are wise, fill in 1 or 2 of these self-monitoring forms also after you have stopped.
Right.
And because I answer a lot of questions on the website Psychosis.net in the Netherlands, and often I get questions from people. I've tapered and I've stopped completely 2 weeks ago, sometimes a month ago or 1.5 months ago. And now I'm getting these problems. And Adele Framer from Surviving Antidepressants, she has precisely the same questions for many years. And it turns out that often it helps if people start using a little bit. That's one part of it. The second part, I would say, is that once you are starting to have these symptoms after you've stopped, go to your doctor, discuss what you can do, and do not wait until you go to your doctor and say, I'm having these complaints now for 4 weeks or something, because that's lost time. And because we don't know precisely why these complaints occur after patients have tapered. One part of the solution, I think, is that if people take more time to taper, at least in a number of cases, this should help. If it always helps, we still don't know. But if you become aware after you have tapered, that's why doctors also should make appointments with their patients, like if you have tapered, be aware in the time after you have tapered if things are still going well. And if they don't, come back, we have to do something. But that's something we still are learning because we don't have enough data. That's why we want to have those data. So that would be my perhaps a little bit long answer.
Right. But then I suppose the problem would be that a lot of doctors really don't know very much about withdrawing and withdrawal symptoms. And I could totally imagine going to my doctor and saying, hey, I've been all right for a few months, and now all of a sudden I'm being beset by all kinds of symptoms. What should I do? And I can just picture her face. As incomprehension. So like, what would you say? And then maybe, what we also hear from people is that for some people it helps to go back on some smaller dose a little bit, and for some people it doesn't help at all, or maybe makes matters worse. What could you say about that?
Well, what I can say about it is that, again, all patients are different. And in some situations, we don't know precisely what causes it. A lot of things can happen. And we cannot solve all problems. And as far as doctors who still don't know this, I think World Tapering Day is contributing to do something about the education, which is important. And the best thing you can do is try to prevent these things from happening. And when they occur, also admit that we do not always know the solution. So it's a matter of trying to find the right solution together with your doctor. And my message to doctors would be, if such a thing occurs, because you are completely right, for some people some things help, sometimes they don't help, tell to your patients, if you are a doctor, that you also do not know precisely what's the best way to proceed and that you have to find out together. I think patients understand this. There is no 100% solution for every problem. We want this, but it's just not there. So better admit it, because we will be better off in the end, all of us. I hope this is clear.
I'm thinking maybe add to that to always proceed with caution and small doses also, or especially in a situation where you get unexpected problems, don't go right back on a big dose if you would consider trying that, but just go on a little bit and better suffer a bit more
No, that's what I mean with
than to
trying.
go.
That's basically the advice that Adele Framer get assessed. Like if you have, and I think that this is also sort of logic, if you have tapered completely and you get complaints, say a month later, then during this month, your body will have more adapted to the situation without medications. And probably that's why even a small dose may help. And one of the interesting things about using small dosages, it sort of defies logic that is 1 milligram of a drug can help prevent withdrawal symptoms, but it really seems to make a difference. And whether there's also a placebo effect involved, that's not so important. If that helps, why not? We are still learning, and we have to try to find out. The one thing I can say is that don't wait too long if you have complaints. And the other thing I want to say, now we are sort of stressing that people can get problems after they've tapered. But on the positive side, we can also say that a lot of patients who have used the tapering strips apparently don't suffer these problems, or not so much. So for a lot of patients, this is helpful, not for all patients, and we cannot solve all these problems, but we should not be too negative about it, because otherwise we are sort of scaring people like you will have problems once you've tapered. And for quite a number of patients, clearly this is not the case. Okay?
Right. And maybe also important to stress, which I can confirm from personal experience, that tapering strips are not a miracle cure, because I started on tapering strips a while ago, but it was also in a period in my life that I was actually extremely busy. And then a couple of upsetting things happened, and I noticed that things were not going well in my head, and I thought, I have to stop this taper immediately, tapering strips or not, I have to stabilize. And no, actually I went up a little bit and just forget about that whole tapering idea until I come into a bit more quiet phase in my life, and then I can try it again, but not think like, oh, now I'm using tapering strips, they're supposed to be so great.
No,
now I can do anything I want and taper at the same time.
No, but in fact, you are doing, or what you were doing, is precisely what we advocate. We better forget about trying to predict in advance how things should go. We should be aware of what happens during the tapering. And in my opinion, this is what, for instance, Adele Framer from Surviving Antidepressants and a lot of other websites, people are telling all along. Be aware to what happens during the tapering and act accordingly. And this can be very different things for very different persons, because a lot of things are involved. But stop using guidelines as a sort of prescription that will always work, because it doesn't. Okay?
Right. And then we have another interesting question. This is about tolerance withdrawal. Well, I assume that you're familiar with that people get withdrawal symptoms between dosages, which is, of course, a very awkward situation, that some of this medication has such a short half-life that people can really not bridge the gap to the next dosage. And let's say you take it once a day, every day at 8 o'clock in the evening. Maybe at 5 in the afternoon, you will start to feel bad already. What's going on there? Well, and this is before they start tapering. This is just a condition that some people have. I've heard it a couple of times. It's not.
It could be, but my first thought is that is this especially for some drugs with short half-lives?
I think it is.
Because
Yeah.
there are questions from people who are using, for instance, lorazepam or whatever, and they say, I use it on 3 different times a day.
Yeah.
But there are also people who are, I think it's quetiapine, if you have the normal version.
Mm-hmm.
Sometimes the solution is to change from one daily dose to 2 daily half dosages. And you can also do that using the tapering strip. So make the intervals between the time you take a pill, make them smaller. But this is also something that needs further finding out. And I'd like to add that I'm interested in the science, but my main interest at this moment is that we solve problems in practice that we can solve now as quickly as possible.
Right.
And there's a lot of things we still don't know. That's also clear.
That's certainly true. Yeah. And well, I have a question here, and maybe the strips that you showed are not completely clear. Someone here was wondering, do you stick them on your skin or do you swallow them? Well, not the whole strip, obviously.
Well, I showed the picture, and
Yeah.
perhaps I was not clear, but because these are these packages, and for each day there's a number on it. The day is indicated.
Cut it
On
open.
that day, this thing you do is very simple. You open it and you swallow all the tablets that are in there for that day, and then you get the precise dosage that is on the information that you get with the strip. And if you do that every day, then actually it's quite simple. You don't have to count anything. Just take all the tablets of that day, and the next day you take the tablets of the next second.
Right.
Okay.
And, yes. And I have a very interesting one here from Kathy. And she's wondering if one is on multiple medication. So let's say you're taking antipsychotics, antidepressives, anti-anxiety, etc., etc. Which should you start to taper first? Do you have any suggestions about that?
Well, actually, I have, because this is not an uncommon question, and it's not an uncommon problem. And there are 2 things. The first thing, we advise people, if they have multiple medications they want to taper, don't try to taper or to stop using them at the same time. This is a very practical reason. If you try to stop with 2 medications at the same time and you start having problems, you don't know which medication is causing it, or they may both causing it. So better, or preferably, do it one by one. And once you have tapered one drug, wait a while before you start with the next one. And then with respect to the order in which you taper, we don't have any research on that. So in principle, it's a choice you can make together with your doctor, but there is a practical consideration. What I always say, save the drug that you think will be the most problematic for you for the last. And practically speaking, if somebody is using an antidepressant and a benzo, then I would think that tapering the antidepressants would be the first thing, because you expect, but this can differ per person, but that would be the less problematic. But for instance, if you have sleeping medication that helps you sleep, save that for the last, and do this very carefully, because if you disturb your sleep and you have still other medications to taper, your problems will be larger. But this is not like there is solid evidence for that. These are just things you have to decide, and I think there is really a choice here. So preferences, I think, may play a part in this. But don't try to stop multiple medications at once, unless, of course, there's a very strong medical reason for it. But I can only imagine that that's the case if you are in a clinic or whatever.
Yeah. This is an interesting question actually for you, Peter. It's David. He says, does the number of strips depend on the starting dose? That's a good one.
The number of strips is dependent on what the doctor and the patients decide how they will taper. So it can be dependent on the dose, but it can also depend on the speed of dose reduction. For instance, you can taper venlafaxine, which is very often used as an how do you call it, as an example. And we have much experience with it. And if somebody goes from 150 milligrams of venlafaxine, he could choose to taper from 150 to 75 in a month, to from 75 to 37.5 in a month, from 37.5, say, to 15 in a month, and then from 15 to 0 in a month. This is just an example. That would be 4 or 5 months. I don't know precisely. But in other cases, there are people who taper from 37.5 to 0 and who take 4 months. So it depends on if patients are having a problem or not. So to make it practical, you can choose to taper a medicine, well, say, whatever, from 20 to 0 milligrams in 2 months. You do so, and it turns out that you are going too fast. So at 15 milligram, you say this is too much, and then you take a slower tapering schedule, and you go from 15 to 10 in a month, and it is still going too fast. So once it's going too fast, you will need more time and you will need more tapering strips. So the number of tapering strips, that's not a given.
Right.
That depends on what you do. And generally, patients want to get rid of their medications as quickly as possible, but they know that this is a bad thing. And it depends on the person, the medication, the situation, and so on. So there's no clear answer to how many strips you should use.
Exactly. And that probably brings us to another question as well, which is very important. And this has to do with the reimbursement of tapering strips. Now, I know that the Patients Association for Tapering has been working and fighting to get this organized. How far do you think they are with that? And do you think they will ever succeed?
Well, I think they will succeed because what I see is that more and more people are using the tapering strips, and the arguments for not reimbursing them, I don't think they stand. As it is in the Netherlands, we have had a committee and who basically said we have people who have, how do they call it? They fulfill some risk criteria for withdrawal. And if they have these, they can get tapering strips, and the health insurance has to at least pay for part of it. And the ones who don't have risk criteria, they basically are not allowed to use them, which is very, very strange, because these risk criteria cannot be used to make this division between patients.
No.
And the discussion is very complicated in the Netherlands. We have had court cases. This thing is still not settled. But I think it's basically a form of big injustice, as I said, that patients are having to pay to come off medication because they are having problems caused by the medication, problems which the pharmaceutical industry has known about for decades, and they did not solve these problems. So it's not clear to me why we would let patients pay for the medication. And it's interesting that in The Economist, a few weeks ago, there was a long and very good article about these problems. And basically, The Economist said the same as what I am saying, like it's not sensible for health insurance to not reimburse this medication. And the same is true for the NHS in England. And they put it very bluntly, and they said, pay now or pay later, because if they don't pay, or I should reverse it, if they pay for the medication, they can save a lot of problems. They can get more people off antidepressants safely. And they made the argument that so many people on antidepressants, where we know that quite a number of them will not actually need them, but they go on using them because they can't get off, and this will result in extra falls and a lot of other problems. And another thing is that if people cannot taper properly, then they can, as a consequence of not being able to taper safely, get all sorts of problems. They can become psychotic, they can become akathisic, they can become suicidal, and whether this is happening often or less often, you can discuss about it, but this is very problematic and very expensive for society if we let this happen, let alone for all the suffering for patients. So I don't see any good reason not to pay for patients helping to come off medication. It's not reasonable. And what I also find not reasonable is that the companies who have caused these problems by bringing these medications on the market are not held accountable for the problems that are now there. I mean, Mercedes had to call 1 million cars back because there was something wrong with the brakes, and they will have to pay for all the damage that that could possibly cause, because they had to make sure that these cars had proper brakes. Now, with the medication, we see something entirely different. They are brought on the market. They have a clear flaw because patients are getting problems when they taper. And what do? We don't go to the pharmaceutical companies and say, you have to solve this. No, we say to patients, now you have to pay for the damage. And this is something I cannot understand. So in the end, I think it will be solved, but don't ask me to explain what is happening about this in the Netherlands. And Jim tried to do this in his talk, so it's a sad thing that we cannot show this.
Yes, but we will be seeing it because I'm putting it on our YouTube channel now. It's just uploading.
Oh, okay. Oh, great.
And it says here still 4 minutes. It has to
okay,
go through cyberspace, and in 4 minutes
oh, that
we
is
will
great.
be able to see it. And then we have a critical question here. I think it's a good moment to talk about this. It's Lauren. She says, if you are involved in the creation of tapering strips and then also research them, is that not a conflict of interests? And she says, how do we get independent, unbiased research? And what do you say to those who then compare you to big pharmacy who create studies based on their products?
Well, I can understand the question.
Mm-hmm.
And my answer is that I started advocating for safer tapering in 2010, actually. And in 2012, I wrote a report together with a retired general practitioner in the Netherlands, in which we proposed for the development of guidelines for safer tapering. And this was before the tapering medication was there, because I had no idea how this could be done. In this report was the idea to make tapering strips. But the tapering strips are basically also based on an idea that was put forward in 2004. So this was all before the tapering strips were there. So, and as I said in my talk, my goal is not to get everybody use the tapering strips. My goal was and still is to help people to use medication better than they often do now. And if they want to taper a medicine, whether it is to get a lower dose or to get off the dose, the important thing is that they can do it safely. And that I'm in favor of the tapering strips is because, as far as I know, it's the only proven tool at this moment that does this. But if it can be done in a different way, if somebody comes up with a much better way, then I would say fine, but I don't see a better way. And also you can ask the question, why is it that a solution that I, together with a few people, could develop in less than a year once we found Paul Harder, why is it that this has not been done by pharmaceutical companies many years ago? Because they knew much more about making such medication than I did. I was in that respect a complete amateur. They could have done it easily, and they should have done it, and they didn't. And so telling me that I am the same as a pharmaceutical company, I find this problematic, although I understand the question, because we get this grant from the Regenboogapotheek. But we have tried to get, and this is an interesting thing, to get money from the biggest funder of research in the Netherlands several times. And each time they told us, what you are doing is not relevant enough. They did not find relevant what we are doing. And in the years after, they have funded a study of 3.5 million euros, which has also been used as an argument by our Institute of Healthcare, by our government, because this study would help to improve the things we are doing. This study has failed. This study has been stopped. There were not enough participants. So there was money for that. There's money for another study of 1.5 million euros that will also fail. So they are given money.
Yes.
We are not given money, and we are producing results. We are doing something. And explain this to me, but I find it difficult to, when I am compared to pharmaceutical companies about this. So that's my answer.